Complex tibial plateau fractures are still a great challenge for trauma surgeons, even though modern surgical progress. In specific, to limit the development of post-traumatic osteoarthritis and limited range of movements, anatomic reconstruction of the articular surface is essential. Modern surgery has been greatly helped with the supplemental techniques such as fracturoscopy, 3D reconstruction from computed tomography scan, and which help for planning fracture-specific surgical approach to achieve a stable reduction and fixation of the plateau reconstruction. The 3-column classification is a CT-based classification system which describes tibial plateau fractures comprehensively using a 3-dimensional concept. Tibial plateau and the underlying bone are divided into thirds, that is the medial column, lateral column, and posterior column. This classification enables a better understanding of morphology of fracture, guiding the surgical management. Appropriate reduction in complex tibial plateau fractures is not easily obtained, especially in the posterior segments of the lateral tibial plateau. The impaired visualization of this part of articular surface, though standard surgical approaches, is the most important risk factor for malreduction. In particular, posterolateral aspect of tibial plateau located at the lateral part of the posterior column is described as the most orders for the orthopedic surgeons to treat because of its difficulties in exposure, reduction, and fixation through conventional anterolateral approach. Incidence of posterior lateral plateau fractures is 15% of total tibial plateau fractures. The treatment of choice in these cases is stabilization with internal fixation or with an hybrid external fixation. In particular, Frost presented in 2010 an innovative surgical approach for posterolateral tibial plateau fractures with the aim to protect the soft tissue and allow good visual control of the fracture reduction. We will be discussing it, sir. So this study have developed a revised Frost approach to manage both the posterior and lateral tibial plateau. Anterolateral approaches. Anteromedial. Post. Especially posterolateral column, involving posterolateral column, which usually needs a fibular osteotomy, sir, to approach to that fragment and to address that fragment. We can the recent approaches have developed, sir, which through which we can approach directly.
So basically, you are talking about surgical classification and 3-column concept.
Yes.
So what is the main difference between surgical classification and a 3-column concept?
I have shown it. So coming to regular Frost approach, which is published in 2010. This is the surgical incision, sir. So usually we take it, it's 12 centimeter incision, 2 centimeters proximal to the fibular head and extending distally along the shaft of the fibula. Here it is the plane, sir. And they are just, we can go with the 2-window plan, sir. Approach is one. Through that approach, we can do 2 windows. So that we can, yes, sir. This is a posterior window and this is an anterior window through which. Sorry.
So the center point of the incision
Dash.
is fibular head.
Yes, sir. So this here, lateral and posterior. The anatomic drawing of lateral and posterior regions of the knee, the dashed back line. This is the skin incision. The lateral standard arthrotomy should be done for this lateral approach, and blunt dissection of the popliteal fossa between soleus and gastrocnemius for lateral approach.
So what is the position of the patient?
Laterals. Lateral.
So it is left up, right up.
Yes.
So can we
Uh, this approach I haven't shown, sir. I showed a modified approach.
This also is there. This is also there. Position on the patient.
I showed, sir. Yes. Through this approach, we can. Yes.
కానీ దీనిలో you can go with the lateral approach. Use your position like this. అందుకే ఆ పొజిషన్ చూపించాలి. With the pillow. ఉందా? అది పెట్టాలి.
This is an old approach, sir. Frost approach. Modified approach I haven't shown. In that I'll show.
Madam, that also when you want to plan for a surgery, you should be the surgeon should assess plant every judgment. All cases are not same. All patients are not same. All fractures are not same. So you should positioning the patient is the తర్వాత turn engineering.
Okay.
Will end up in trouble. That's why they are talking about surgical and 3-column concepts. That is the main difference. In surgical classification, it is a radiological classification. Whereas 3-column
Yes, sir. Sure.
CT classification. CT is different from radiology totally. That's why anterior medial column, medial column.
I shown it, sir. I'll explain.
Again divided posterior medial, posterior lateral. So total difference comes with the posterior column. See, intra-articular fracture, anatomical reduction, and articular congruity should be maintained to prevent early onset of osteoarthritis and loss of functional capabilities. High demand function, ultimately is the function.
Yes, sir. So, okay, sir. After lateral arthrotomy, the popliteal fossa, here we can see this. This is the lateral approach, sir.
That's not the fossa showing. Fossa is posterior, right? You have shown difference between the psoas as well as gastrocnemius. What is it?
And this is after plating, sir. Plating is done. In the previous picture, we can see this is the fracture involving posterolateral column and is addressed through the regular Frost approach. And this is the case done through Frost approach.
Where is the popliteal nerve? Common peroneal nerve, yeah?
Here, this is the common peroneal. This is a common peroneal nerve. This one.
Major nerve?
No, now we should retract it laterally, sir, so that we can place the plate.
So the relationship in the popliteal fossa is AVN, popliteal artery, popliteal
Vein and now.
So lateral is not AVN. So medial to lateral. So it should be very careful.
Yes. So this cases done through Frost approach published in a journal in 2010, sir. It's a conventional X-ray in 2 planes, 18 months post-operatively. The posterolateral fragment was fixed with a posterolateral plate. In this case, an additional lateral buttress plate was necessary to fix the lateral main fragment. As demonstrated by the X-ray, anatomic reconstruction accompanied by complete fracture healing was achieved. The patient reported no pain, could use her leg normally and was able to work. A clinical examination revealed no tenderness on palpation and the ligaments were stable with a free range of motion.
Can you get a genicular arteries in the popliteal fossa?
If we go inferior distally, we can get.
So genicular vessels also there.
Yes. Coming to materials and methods, the studies, this modified Frost approach conducted in 11 patients with posterolateral tibial plateau fractures and have been treated with the open reduction and internal fixation using Frost modified surgical approach and that they have developed. The group was composed of 6 men and 5 women. The average age was 64 plus or minus 21 years old. 4 tibial plateau fractures involved the right knee and 7 fractures involved the left knee. The tibial plateau fractures were classified using 3-column classification system. Of the 11 fractures analyzed, 6 were of the type 3 fractures and 5 were of type 4 fractures.
What is type 3? What is type 1?
I'll explain it here, sir. Yes, sir. This is a 3-column classification. Here, this is actually divided into anterior, medial, lateral, and posterior. Posterior is again posterolateral and posteromedial. It has 4 types. The type 1 is 0 column, that is isolated articular depression fractures, which is similar to Shaziker's type 3. And type 2 includes 1 column fracture, that is simple split and split depression fractures, lateral and lateral one column, mostly type 1 or type 2 Shadkus, and posterior one column. There is no Shadkus classification for posterior column. And here, as they have mentioned, type 3 fractures is two column fractures, which means it involves any of the two columns among those 3 columns. That is anterolateral with the posterolateral, or anteromedial with the posteromedial. And last one, the type 4 is a most common type, which is a bicondylar, that is Shadkus type 5 or 6 with a separate posterolateral fragment.
This is అది లేదంటే ఒక పొజిషన్ దాన్ని modification this is the position అది దాన్ని modify చేయాలి. So the positioning only is other. So before intra-articular fracture, the basic fundamental principle in orthopedic for management of intra-articular fracture is there is nothing like two plane images. We want three plane construct. What is that three plane construct? What is three plane construct?
3 CD CT 3D CT 3D CT I will tell you.
Two-dimensional. Your CTs are three-dimensional. Yeah, better. Concentrate. Go ahead.
So coming to surgical technique of modified Frost approach, we have already seen the conventional Frost approach. The patient lies in a 3/4 dorsolateral position. The skin incision is about 12 centimeters in length and runs. Sir? We should keep the patient in a lateral decubitus position and tilt to 20 to 30 degrees towards. Yes, sir.
Complete posterior. Prone.
Prone. Complete line. 0. 3/4. So the incision is 12 centimeters and it is shaped. It begins 2 centimeters lateral to the tibial crust and 6 centimeters below the tibial tuberosity and is directed proximally.
Is about 12 centimeters in length and runs a S shape with the center positioned over the head of the fibula.
Skin incision is about 12 centimeters in length and runs in a S shape with a center positioned over the head of the fibula. It starts 2 centimeters laterally to the tibial crust and 6 centimeters below the tibial tuberosity and is directed proximally, curving posteriorly at the level of fibular head and returns straight to the proximal part. It terminates 4 centimeters posteriorly to the lateral femoral condyle. So this is the position, sir.
These are images, very good images. It is from Italy.
Yes. After opening of the subcutaneous tissue, we can identify the fascia which is open through the incision. Subsequently, common peroneal nerve must be identified. The nerve is isolated and protected with a vascular band and moved anteriorly.
Yeah, of course, from here. Where is the nerve there? In place of the head or the neck?
It winds around the neck or it comes out of the neck.
It winds at the neck.
Okay, but on table, you know, we have discussed how to see it. Right, you can't cut, right?
Yes.
So that possibly you have to come here, not to distal. Possibly put the hand behind the biceps now, palpate it, and then from there you can dissect it. This is the question here. From where it comes to this area, where it can enter with the is longest and then go further. That's what the area is. So identify is important now. This is the head, this is the neck here. Now from posterior you can palpate from here. Under your fingers, and from there start dissecting it. Sometimes both are seen to the same as if it's a tendon. So that should be very careful in dissecting it.
Yeah.
This is under tourniquet only. Without tourniquet you can't do.
Yes.
This tourniquet applied or not?
Applied. The nerve is isolated and protected with a vascular band and moved anteriorly. Here we can see it is moved anteriorly. So open the window between the underlying muscle tendon structures, that is biceps femoris tendon anteriorly, lateral gastrocnemius posteriorly in the proximal part, and long peroneal muscle posteriorly in the distal part. So none of the muscles is cut or damaged during the procedure. The posterior proximal position of the lateral gastrocnemius protects the popliteal artery and the vein. The posterior face of the soleus muscle is reached and exposed. Here. Here. It is, yes. Gastrocnemius, biceps.
So this is soleus here.
Yes, sir.
Completely the process starting from here. So where is nerve supply to this? Soleus? No supply there. Soleus has how many heads?
Soleus has on gastrocnemius too.
Only one head.
Gastrocnemius has 2 heads.
Soleus has both origins. Nerve supply is dual supply in soleus. That's important.
So the soleus muscle must be dissected and separated from the tibial posterior surface, as it is reflected here. In this phase, it is important to identify the lateral inferior genicular artery and to tie it to avoid bleeding. After an accurate dissection, a good view and control of the posterior face of the fractured tibial plateau and epiphysis is obtained. In case of tibial plateau depression, it is possible through this window to use a chisel to lift the depressed articular surface and eventually insert a bone graft to fill the bony gap. The synthesis of the posterior tibial plateau is performed with a 3.5 T-shaped plate. Once the posterior part of the plateau is fixed, the same surgical access allows the surgeon to proceed with the lateral fixation. The common peroneal now is moved posteriorly and the standard lateral approach is performed. The detachment of the extensor musculature from the anterior aspect of the interosseous membrane leads to anterolateral face of the tibia. It's therefore possible to proceed with a traditional lateral tibial head buttress locked plate fixation. By taking the advantage of patient's position and hip external rotation, the standard medial access can be performed to complete surgery with a medial open extension and internal fixation. At the end of the procedure, a surgical suture is carried out only on the fascia and the subcutaneous tissue, being carefully not to trap or injure the common peroneal nerve.
Show me the first exercise. Okay. Go back.
Yep.
Alright, now this is what the position is. Now instead of doing this, can we go from here and make it come vertically here? Or no, down?
Extended incision. Can you make an extension
No,
in
this
this
is the
here?
femur,
You can
right?
extend.
This is the tibia.
Yes.
Now instead of doing on this much section, can I go from here and make it holistically directly here? That's what you, when complete prone position, you can have this crease
L
can
shape,
use,
L shape.
then L-shape downward slope. Can you just expose? But there is a need to expose everything just there also can expose it nerve. But here this looks more easy than putting up the above and coming down. Not much difference is there. The advantage is there in this and the normal approach what you do.
Soft tissue healing there only.
Vascular bundles.
Vascular bundles.
Even you retract the full edge.
Less chance of injuring the common peroneal nerve and vasculatures.
What the instance of stiffness here? First off, we can mention about stiffness.
Yes, sir. In this, through this approach, stiffness is almost zero, sir. They haven't seen any stiffness in any cases.
You open the joint also.
Sir?
You open the joint,
Yes, sir.
arthrotomy is done.
Arthrotomy is done.
Completely. What about the meniscus?
Meniscus. They haven't mentioned anything. They did not mention.
So input is 4 point. This is 4 point. See, this is under tunicate.
Yes.
Number 2 is when you are putting a retractor, 4 months retractor thrombus. It is not only injuring the genicular vessels or the major vessels, even the spasm. The spasm ante already ఉంది కదా. Tunicate అంటే the vessel goes into spasm. It is both venous and arterial. Am I right? Only venous or arterial?
Don't know.
So only venous. So it goes into spasm. The surgery lasts up to 45 sometimes they land up in problems. So should be careful. That is most important, dangerous. అది అన్ని గుర్తుపెట్టుకోవాలి. So never give a small tourniquet. It should be a pneumatic tourniquet. Always you cut off and on it, off and on procedure.
Yes.
How frequently you cut off the pneumatic tourniquet?
After 2 hours.
2 hours.
1.5 hour to 1.5 to 2 hours. Coming to results, good radiographic fracture reduction and stabilization was achieved in all cases during the surgery. These are the few case X-rays. Anteroposterior and lateral knee radiographs of a 79 years old male who sustained 2 columns, that is type 3, tibial plateau fracture at 5-month follow-up, demonstrating the final outcome and positioning of the lateral and posterior plates. Yes? Yes, sir. Through this. Yes. Yes. No, sir. I haven't.
Why do you want a small plate?
Sir. Yes, sir.
What is that posterior? What is the name of the plate and what is the important of the plate?
That's the plate, T-plate used to fix the posterolateral fragment.
So you want to construct the articular.
Yes.
Articular construct.
Here the joint looks incomplete. Do you think it's normal? It's still incomplete.
Yes.
No. It's still okay, but
It looks.
still here. The communist looks here. Not much of this.
Not much.
What is the normal tibial slope? What is the normal tibial slope?
Three
Posterior slope.
3 degrees.
3 degrees.
3 to 5 degrees. 3 to 5 degrees.
Totally on the
7 to 9 degrees.
Other hand. Yeah. So the subsequent CT analysis after 3 months showed that the fracture depression displaced and separation were all reduced. The overall volume of the tibial plateau taken from the articular line to the proximal apex of the tibial tuberosity was incremented with a mean 28% when compared to the preoperative volume. 7 patients out of 11 achieved 97% similarity to contralateral tibia. All the patients reported good clinical outcomes and returned to activities of daily living. They haven't.
minimal or maximum.
That they haven't mentioned.
I don't think they'll complete the flexion and extension.
No.
What is the meaning of concept? 3-column concept and దాని కోసమే చేస్తాం.
Yeah.
So have good functional result. Yes, ma'am. Very good point.
So coming to discussion, the posterolateral side of the tibial plateau has an essential role in the movement of knee joint, and not optimal reduction leads to instability. About 15% of all tibial plateau injuries demonstrated a posterolateral fracture fragment with an average depth of approximately 10 mm. 3D reconstruction has greatly contributed to improve surgical treatment. In particular, the posterior part of the tibial plateau has always been difficult to deal by the standard lateral and medial access, as it is difficult to reach and dangerous to approach with those surgical access. For this reason, several posterolateral approaches have been proposed over the years. They can be divided into approaches with and without osteotomy of the fibula.
Now we are doing fibular osteotomy.
No, sir. Approaches with the fibular osteotomy, such as Lobenhofer axis, allow a good tibial plateau exposure but are burdened by extensive damage of the posterolateral soft tissues. Lobenhofer axis is usually for posteromedial, to address the posteromedial fragments. In fact, 50% of cases of a failure with this procedure are due to the consequent joint instability. The greater limitations are the need to perform the fibular head osteotomy and the complete dissection of the common peroneal nerve. For these reasons, they have been gradually abandoned and replaced by approaches without fibular osteotomy, beginning from Frost approach, followed by variations of this technique developed in recent years. So these are few approaches for posterior approaches.
So the image is so beautifully presented. Cranial, caudal, medial. These are very good.
So lateral. So this is a Lobenhofer approach or direct posterior posteromedial approach, and direct posterior approach is this one, through which we usually do along the fibular head, and S-shape approach and the posterior medial approach, this one, and reversed L-shaped approach.
I can approach both the condyles with a safe position from here, starts again from here. Both can be easily approached safely can be done. But what we do, we never have problem. But this is, if it is both, you can easily go from posterior side, expose completely, as you do for the cerebral palsy. Both heads can be cut, and completely taken off, both condyles can be seen easily and fixed. Small bits, but not a big bit. Small bits can be.
There is no direct incision in the popliteal fossa. Don't go back. What is E?
It's a posterior lateral approach.
Other name for posterolateral approach.
Frost.
So there is nothing as straight line incision. No straight line incision. What is that? E. E and I no straight line. S-shape. Otherwise, popliteal fossa you develop tension.
Conventional Frost approach is a straight line, sir. Modified is S-shaped.
No straight line incision చేయకూడదు.
Yes.
Flexion. Otherwise, wound resistance will be very high. So we are compressing the structures and delaying the wound healing and high chances of wound resistance also.
Yes.
No straight line incision.
The main disadvantages of these techniques are the large skin incision that can cause pathological scars in a sensitive area, the difficulty. Scars may cause contracture. The keloid. The difficult.
What is the difference between keloid scars versus hypertrophied scar? Keloid scars are progressive, they never stop.
Hypertrophic or stable. The difficulty of exposing the tibial lateral face due to the poor mobility of the common peroneal nerve. The high frequency of damages to the posterolateral tibial plateau corner, and the impossibility of approaching the medial face of the tibia without changing the patient's position. So these problems are overcome with the modifications described in this present technique. Following the course of the common peroneal nerve as much as possible, it is easier to mobilize it sufficiently in order to work comfortably both on the posterior and lateral face of the tibia, avoiding to stretch it during the reduction maneuvers. The single smaller size incision presented allows to better respect the surrounding of soft tissues compared to the standard approaches. Moreover, the 3-4 lateral position allows the surgeon to work comfortably on both lateral and medial tibial sides in case of complex tibial plateau fractures, taking advantage of the hip extra rotation. So the main limitations include small number of patients. It is conducted only in 11 patients and short follow-up period. Now lesion 18 months in.
So when do you call it is a short-term study, mid-term study, long-term study? Anything less than 3 years is short-term. 3 to 5 years or 3 to 6 years, more than 3 to 6 years, or 3 to 6 years is mid-term. More than 7 years, running 8 years, long-term business.
Posterolateral we have done many years with the hockey stick incision, not the complete thing as a straight one. We did that. I don't know why this supposed to.
So it is a short-term study.
Yes.
11 cases. Italy.
Yes.
Yes.
So what do you want? You message now. You want to do that?
Conclusion. Yes, no.
The surgical approach presented in this paper is a simple innovation of a surgical technique, but allows the trauma surgeon to expose posterolateral tibial plateau fractures better and treat them successfully. The single incision described here consents to treat both the posterior and lateral tibial plateau fractures when they occur together. Accurate knowledge of regional anatomy is essential to performing this technique, and in the Management of these injuries, the optimal exposure of bone injury and the preservation and protection of soft tissue obtained with this approach allows the surgeon to manage posterolateral tibial plateau fractures in a best way possible. That's it.
What about the cruciate ligament if it is there?
That also should be addressed, even if it is.
Is it there? Always possible with the posterolateral cruciate ligament avulsion is there from the posterior side. But
Yes,
that's
sir.
what we do always when the posterior want to fix it, when we do transfer like this. Expose completely posterior side, fix the tibia. At the same time, the fix it and then condyle also. That's what we do. Right.
Yes.
Can I add one more point?
Yes,
So
sir.
you are talking about column fracture of proximal tibia. Column concept of proximal
Tibia.
Yeah. So you are showing all the plates. Is there any role of ETN in column construct of the tibial plaque? Yes or no?
No.
No. Yes, Lakshmi? ETN. That's what ETN. That's what ETN people are talking. You can address the posterior column also. It was presented. It was presented by our Sai Reddy. Where is Sai Reddy? Is there? Is there? Sai Reddy. Sai Reddy. I have a presentation. ETN presentation of site. We have got cases.
Yes,
So these are the challenging. That is also one of the points. So
Yes.
you said the surgical trauma. The surgical trauma plate gives more surgical trauma than the nail. So that is a newer innovation techniques. You said recent advances. Still you want something. You are talking something now. This is in 2000. Which year? 2024. 24 kada. Italy. So study.
అది 21లో అయింది సార్.
So your conventional ILN cannot give column construct. And usage ILN uses plate cannot use. So that is the reason. So that's a newer innovative. అట్లాగే ETN మాదిరిగా DTN. What is DTN? Distal tibial nail. Usually చేసే distal tibial కాదు. దానికి కూడా multi-lock system. That's a newer generation. Innovative complex. One train చేసే complex system.
Yes, sir.
That is also they are not enough. So we have the anyone you had open. We have open like this. So depends on the morphology of the pathology. Fracture morphology is very important to plan for the management. Fracture morphology,
Yes, sir.
Fracture morphology is very important to plan for the management.
Management.
So what way high velocity injuries are different with the fracture morphology? What way the high velocity injuries associated with your fracture morphology?
High velocity combination is there. Low velocity surface.
Yes, combination.
In high velocity injuries, you cannot describe the fracture pattern nor the classification. So it's very difficult. It's a complex. They may present like bag of bones. How do you fix the bag of bones? You have to wait.
As we discussed Frost and modified Frost approach, we have a case to discuss. That is 35-year-old male with a closed comminuted tibial plateau fracture of right knee. It's a type 2. Split depression. CT ఉంది.
Zoom, reconstruction image ni zoom చేయండి.
చూపించాలి.
Classify the lateral one according to your classification now. Combination is there. That's the problem. But is it complete condyle or posterior condyle?
It's involving two columns,
What is the
lateral and posteriors.
coronal images? Which are the sagittal, which are the coronal? Coronal is sagittal. What images are there?
a standard classification of lateral condyle fracture or the posterolateral fractures here?
Posterolaterals.
That one.
Yes. Posterolateral.
Not the true standard classification.
Yes.
There is combination and depression.
Yes, OCS.
Both.
For extension.
Yes.
Combination and depression, both of it. So, that is good.
So what is the classification?
Reconstruction measures. ఇప్పుడు వీటి అది see, now you can see. చూసాను reconstruction. Now you can see articular congruity and so much of combination. See the articular congruity and combination.
Yes.
It looks simple. Now you can see.
It's involving 2 columns, sir.
Medial also? Where put on the middle column? Lateral and middle.
Lateral and
Posterior middle.
posterior.
Not middle, right. Okay. What is type of injury?
Sir,
Injury, what is the type?
he fell
Direct,
direct injury.
Direct injury అంటే ఆపేనా?
falling, where? Fall from the height or from the head? What from the height?
Fall from bike, sir.
From the height.
Bike. Yes. So we have fixed it. It's a cases done in Unit 3, sir. It's a Nasimlu 35-year-old male with a closed comminuted tibial plateau fracture of right knee. It's a type 2 Schatzker, sir. And it involved 2 columns, the posterior and lateral, sir. So it's a case to do with the posterolateral approach.
For the benefit of the
Benefit.
juniors,
Yes.
how many columns are there? Tibia.
3 columns.
What are they?
Medial, lateral and posterior column. Posterior is again divided into posterolateral and posteromedial columns.
Right.
Yes.
And
Middle. Yeah. So
yeah, okay.
we have fixed it with through open reduction and internal fixation with the 5-hole right lateral tibial LCP and recon plate for right tibia. We did it through posterolateral approach.
So what is the main aim of treating intra-articular fractures?
To
What is your aim?
to
In
maintain
treating-
joint congruity and to allow the range of movements and to delay the osteoarthritis, to prevent the onset of.
You can't delay that one, but what is your aim at the time of treatment? What is your objective? You're right. Put it in a
Maintain-
proper way, scientific way. Put it in scientific way, whatever you said. You said
Slope.
congruity. So what does how do you achieve congruity?
Through absolute fixation.
Well, he's prompting you, but prompting the wrong one. Anybody? How do you achieve congruity? So anatomical reduction,
Okay.
isn't it? So you get back the anatomy. That's the basic thing. That's how you get back the congruity and prevent secondary osteoarthritis. Okay. And what is the second aim? You said.
Range of movements.
So what do you want to achieve? Range of movements means doesn't mean anything.
He should be able to do his daily activities. With
That's
daily
later on.
living.
What is your immediate aim as a doctor? What you're going to do for him? You said
Mobilization,
achieve anatomical reduction.
Reduction.
Okay. Second thing is
stable fixation.
stable fixation.
Fixation.
Okay. But
And
that's also part of. So if you have a stable fixation, what can you do?
early mobilization.
Yes, that's important. So anatomical reduction and fixation of stable fixation and early mobilization that will prevent what complication? If you mobilize the joint early, what complications it will prevent? Yes, what complications?
Stiffness.
So it will prevent stiffness of the
Stiffness.
joint. What else?
DVT.
Okay, DVT is a second. We are not interested in DVT, isn't it? Medical. Orthopedic wise, what are the other things which will prevent? If you make the joint immobilized, what will happen to the joint and surrounding structures?
Con.
Don't take properly. Answer properly.
Arthritis.
One person. Yes, you sir. Take a mic. Come to the mic. So what? These are the basic things you should know when you're treating. When you become orthopedic surgeon, you should understand what is your aim, what patient wants. It applies to all the fractures, isn't it? So, early mobilization, what it prevents? It prevents stiffness. Also prevents,
arthritic changes, sir.
okay, muscle wasting. Yes, it prevents. See, all of you join together, I think, prevail good orthopedic surgeon. But I want to individually become good orthopedic surgeon. So it prevents muscle wasting. What else it prevents? Bone weakening. What do you call?
Osteoporosis.
Disuse, osteoporosis. Basic things. So repeat again. What are the things?
Prevents joint stiffness.
Yeah.
And muscle wasting.
Yeah.
And disuse osteoporosis.
So it prevents stiffness, osteoporosis, and
muscle wasting.
so initially what you have to do, weight bearing is not allowed, but range of movements you should move the joint through full range of movements. How joint gets its nutrition? Articular cartilage,
Synovial.
synovial fluid. Okay, yes, synovial fluid. How the fluid goes into the articular cartilage? You're right, synovial fluid is good.
With the
If you
movement.
just put the synovial fluid without movement,
No.
will it go into the articular surface?
With movement, it goes.
Yes, so every movement, it's a passive diffusion. The nutrients, these are the basic you might have read in pathology. But important. You have to explain to yourself, your patient, and everybody. Unless you make them understand, they don't do it. So it's a passive movement,
Movements.
diffusion, simple diffusion. Simple diffusion, which will help nutrients get into the articular. That's how. That's why in osteoarthritis, any arthritis, rest is no good. If you go to most of the doctors, what your joints worn out, take rest, which is very bad advice. Normal joint needs mobilization. Arthritic joints need more because more nutrients. Okay, go on.
Yes.
Sir, 60 years female with intertrochanteric fracture of right femur, sir. It is type 2 Boyd and Griffin type. And we had done close reduction internal fixation with proximal femoral nail, sir, for right femur, sir.
See, the recent studies have shown even if you reduce the lesser trochanter, anatomical reduction will have better results.
Yes, sir.
So put a wire. We discussed in the past. So minimal opening and put a wire across. Who has done this?
Me, sir.
No, that's good, but it's valgus. You have to reduce lesser trochanter. That gives stability. So a stable fracture. See do you know how the fracture gets its strength? By just fixation or anything else? Putting a metal, will it give full strength to the fracture site?
No, sir.
What else?
With reduction and
Yes, if you have good reduction, stable reduction, that itself will give stability. And you maintain that with it. If you just depend on the nail or a plate without proper reduction, what happens is it will fail. If fracture doesn't unite in so much of time, it will fail. But if you give stability by reducing as much as possible, it gives more stable fixation. Okay, go on.
It is 8 years old boy with 3 weeks old complex second metacarpal phalange joint dislocation of right hand side. It is a Kaplan lesion, and these are the intra picture. We have it's a Kaplan lesion, sir. We have tried, sir, but we were unable to. No, sir. It was 3 weeks old, sir. 3 weeks old. Yes. Even with if it is if it is complex dislocation, we have to first flex at the wrist, sir, followed by
Why?
hyperextension at the
Why flex the wrist?
to
Relax the flexors.
relax the flexors, sir.
Some people directly they want to pull it out, it will not come, it gets locked. The best thing is flex the wrist first.
Flex the wrist followed by
Then you get
hyperextension,
That,
and
that's the way
we
to
have
do it.
pressure at the
Right.
proximal joints.
So this is what Kaplan
What is this? It can happen with any joint. Can you repeat again? Benefit of everyone. Kaplan, you repeat. What is it?
Dislocation of the second metacarpophalangeal joint.
Yeah. And what is Kaplan?
Complex.
Kaplan is a complex.
Entrapment.
Kaplan lesion is the joint, the round part of the joint comes out through the capsule, and the capsule gets entrapped around the neck and difficult to reduce it. Every time you reduce, the capsule goes into the joint and comes back. Even if it's reduced, it's incongruent to reduction. So whenever you see incongruent reduction, there is soft tissue interposition. Okay.
always there is fracture, the flake from the head. Head of the metacarpal, there is some flake which is from intraocular, that also gets locked.
Yes.
So we'll have to see completely and then see. Now what the approach you wanted to go?
Dorsal approach, sir.
Why?
We can fix both. We can have
Commonly describes only volar approach, right? People do
in
it.
volar approach. We have risk to injure the neurovascular structures, sir.
Can you describe Kaplan's lesion where volar approach can see the head? What are the things medial, lateral, anterior, posterior?
Yes, sir. I have mentioned in the EVN slide, sir. Superiorly we have
You described
lateral
already.
ligament,
Yeah.
and on the medial side we have flexors,
Yeah.
and on the lateral side we have
Okay, that's what Kaplan's lesion is. That's what. The volar plate is on volar side, right?
Yes, sir.
Which is easier? Is it dorsal approach or the volar approach?
Dorsal approach is
Easier. You
Yes.
can split the extensor
Volar
tendon completely, you can pull it out. Otherwise, if you go from volar side, always a problem. You'll have to again come to the dorsal side. Many times, Rasim tried to do that. I said, don't do it. Directly go to the dorsal side, anything, every joint. Dorsal approach is the best approach, you can easily go to it. But if you go from a palmar, or it's very difficult, something can injure the vessels there also. That's what.
these are the intraopic sir.
Okay. So we need to put the KMR, if it is
We had fracture at the neck, sir. So we have put the K-wire.
So the flake from the head, flake.
Head.
Neck pulled out.
Head.
Neck gum is gone. The neck fracture is there. The flake of the bone is head of the metacarpal that gets separated. Always. That's the
Yes, sir. X was taken. Yes, sir. These are the movements, sir. After reduction.
Okay.
It's stable, sir. This is exercise.
Okay. Next one. Why you are not able to play from a PowerPoint video? But you full screen, not able to play. That means you don't know how to do proper PowerPoint presentation.
able to play, sir.
Why we play it again? Without full screen. Can you play with full screen? Put full screen. Not plain. Go on. Play. Okay. So you included video in the folder. Yeah. Okay, go on. Very good. Excellent. Go home and make some notes, all of you. What you learnt from today teaching. Make a small notebook so that it would be useful for the exam as well as for routine practice.
Good morning, sir. These are the cases done in last week in
Speak into
Unit.
the mic.
Good morning, sir. These are the cases done in Unit 2 last
Louder.
week. Yes. These are 28-year-old female, sir, with grade 1 distal third fracture of right humerus with intra-articular extension, sir. And these are the 3D CT images, sir. And it comes under Jupiter type 3 classification, sir. Y-shaped.
Show me normal plain CT. Plain CT is more useful than 3D.
Yes, sir.
3D will have artifacts unless you able to see the plain CT. Plain CT is there? No.
Yes.
Where is the plain CT?
They're not included in this. Take.
You get very excited with 3D, but 3D is sometimes misinformed, information by 3D CT. So you have to have plain CT.
Yes. We have done the Campbell approach, sir, and we have applied the posterior lateral plating, sir, and intercondylar screw, sir, with olecranon osteotomy.
Who did this?
Narsimul, sir. Intra-articular extension we have. Yes, sir. Yes, sir. Actual medial cell there is a rigid fixation, sir. This fragment was attached with the soft tissue, so we have left over that one, sir. And
But it will be unstable.
yes, sir.
You have to put a little plate, maybe 4-hole plate. Both columns, if you support one column, the other column will collapse.
Yes. We have explored, sir. Both nerves are.
So you have to put a little plate. This plate should have been with more lateral and the medial side. That's a classical description.
Yes, sir.
Otherwise, it will go into varus collapse.
Okay, sir.
Because fragments are there unless you put a small 1/3 tubular plate
Okay, sir.
with the two holes proximal, 2 hole distal. Okay.
A 38-year-old male with a closed middle third shaft fracture of right tibia, sir. We have managed with
That mic is working, not working.
we have managed with closed reduction internal fixation with interlocking. Considering the age, sir. There is
38 or more than 38?
38, sir.
Look at the knees. What is there? Osteoarthritis. Had any injury in the past to the knee?
No, sir. No, sir.
Yeah.
Yes, sir. Yes, sir.
But I think you justified 38. Early mobilization, functional cost. Problem with plaster is difficult to apply. Compliance, every week you have to check with X-ray. Might get rotational deformity, especially single bone. Single bone is an indication for fixation. If both bones, probably we can do plaster, but single bone. Okay, I would do the same.
28-year-old male, sir, with a grade 1 compound, both bone fracture of left forearm, sir. He had a wound on the ulnar side, sir, and abrasion, sir. We have fixed with open reduction internal fixation with nailing for ulna and small DCP, 8-hole small DCP for radius.
Yes, okay. Why not a plate other side?
There is a wound.
All right,
There's a wound
okay,
and
okay.
abrasion.
Justified. Next one. So you have to speak clearly, practice yourself. 50% is subject, 50% is communication with anybody, even with patients, colleagues, students, everybody. Say whatever you say clearly. Don't mumble.
Good morning, sir. These are cases done in Unit 1, sir. It's a 55 years male with closed distal third shaft fracture of tibia with proximal third shaft fracture of fibula of right leg, sir. We have done closed reduction internal fixation with interlocking nail for right tibia, sir.
How old is the patient?
Sir, 55 years.
Huh? 55, okay. Look at the knee.
Changes are start.
Okay, okay. Go on.
75 years male, sir, with fracture neck of right femur, intracapsular fracture. It's subcapital type, sir. We have done cemented bipolar hemiarthroplasty of right hip, sir.
Who has done this?
Jairam, sir.
Okay, go on. Looks good.
Yes. So 51 years female, sir, with intertrochanteric fracture of right femur. It's Boyden Griffin type 2, sir. We have done closed reduction internal fixation with proximal femoral nail for right femur. 30 years male with closed proximal third radius shaft fracture of left forearm, sir. By dorsal approach, Thompson's approach, we have done open reduction internal fixation with 6-hole semitubular plate for left radius.
Go back. What type of fracture it is? If two bones are there, one is broken, displaced. So what should happen to the other one? It should get fractured or dislocation. Is there any fracture or dislocation?
No fracture dislocation for other bones. It is fracture and the distal fragment is displaced.
But why? How can it displaced without?
What type of injury he had? Direct or indirect?
Indirect type of injury, sir. Yes, sir. No, sir. No,
Probably-
please fall from bikes.
Probably there is some degree of subluxation, but it has to. So if this fracture was here, what do you call? Put the phones in silent mode. If fracture is there, what would you call?
Gallage.
So it could be variant of
Variant of gallage.
variant of gallage. Okay, go on. So this is also treated as,
Variant of gallage.
so treated as intraarticular, extraarticular fracture.
Intraarticular.
Intraarticular fracture. Okay, good.
14 years male, sir. It's closed middle third shaft fracture, both bone shaft fracture of right leg, sir. We have done closed reduction internal fixation with titanium elastic nails for right tibia, sir.
Yeah, okay.
It's a similar case, sir. 15 years male with closed middle distal third junction of shaft both bone fracture of right leg, sir. We have done closed reduction internal fixation with
Same accident or different? They're not related to each other.
not related to each other, sir.
Okay. Good.
53 years female, sir, with
You are the only one in the unit or anybody else is there? Who else assisted? They are in operation.
Viviana is in notice.
Okay, go on.
53 years female, sir, with intertrochanteric fracture of left femur.
Yeah.
We have done closed reduction internal fixation with proximal femoral nail for left femur, sir.
Okay. Again, I said go back. This has to be, see, little incision, maybe too small, but wire always. Try to do that.
Okay, sir.
And there is a rotational element. Can you see? This is not reduced.
Yes.
Not reduced. Neck is that way. Next.
31 years male, sir, with grade 2 compound proximal middle third junction of right tibia. We have done open reduction internal fixation with locking compression plate for right tibia, sir.
Why not nail?
Because it is the proximal third, so it is difficult to get the screws and
Well,
proper
you can easily
reduction.
get 2 screws. You can get 4 screws there.
We can get by with the expert tibia nail, sir. With
Well,
the
see, the
interlocking
distance
nail
is from to there.
at the it is the fracture is at the proximal third, so we have to take a lateral to the intercondylar spine.
Okay.
25 years male, sir, with closed middle third shaft fracture of right femur. We have done closed reduction internal fixation with ILN for right femur.
Okay, good.
So, pediatric case, sir, 7 years male with equinocavovarus deformity of the left foot, sir. Here it is a gait video. The equinus gait is seen. So the causes may be here it is idiopathic, but the causes may be here idiopathic and some neuromuscular and degenerative causes are there. So
Degenerative.
neuromuscular disorders. And so for this process, so here it is equinus and cavus deformity. So we have to do stainless release and TA lengthening. Stainless release is it is a contracture release of the plantar fascia, sir. We have to do subcutaneous fasciotomy and release of the first layer of muscles, abductor halsis and short flexors and abductor halsis, short flexors and abductor digiti quinti. We have done stainless release and also TA lengthening by jet plasty, sir. Sir? We have to measure the angle. Yes, sir. We have to measure the angle, sir. With the foot in equinus, we have to measure with the horizontal line drawn. Yes. Yes. Half of the it should be the lengthening done to the.
Understood?
Yes, sir.
Good.
Sir.
Done?
Yes.
You should always add. No need.
So you can have a dynamic X-rays. These are the cases where when you want to do, you can have a dynamic images. So that is give a better clarity. It's coming or not. So there is dynamic studies.
How many cases are pending?
7 cases are there.
7.
Yes.
You need 2. 3. It's because you didn't get cases or you done more? Why less number of cases? So if rain comes, only one will get cases. Make sure you make notes. Go home, take the copy for it, so that you remember during exam, everything, or during the practice of forever. Nowadays, very easy to make notes. Make notes because tomorrow you forget. If you listen once, write once, remember it. Writing is always important. Okay, thank you.
వస్తున్నా. Let me explain. Yeah, put this. ఈ ఫోటో బాగుంది.